Um, this is a new talk that I'm giving. It's still in development. I've not given it before, so I'm still working on it. It's obviously not a problem that's relevant to people working in a setting where you're seeing serious mental illness in an inpatient setting. But I think increasingly there are people in psychiatric practice for outpatients in places like Nairobi where this kind of issue starts to come to the fore. And I think conceptually it's very interesting. So what I'll do today is I'll talk to you about three things: a little bit about the background to this issue. I'll give you some empirical data, and then I'll give you a conceptual framework. So let's start with the background and history then. And I just want to give you, for people that are practical, just give you three cases to think with: A, B, and C. So A for Adam, he's 20 years old. Sorry, Yossi, this has gone way beyond the rule of six. I just realized that now. Okay, this is someone with severe social anxiety disorder, comorbid depression, selective mutism, major depression, can't go to college, can't work, psychotherapy doesn't help. Are you going to give an antidepressant? Okay, I think that's pretty straightforward. This is a little more tricky. It's fairly straightforward as well, but some people may disagree. This is Beth, not very comfortable in social situations, worked in a small town, then she moved to Nairobi. And in a larger company, she was uncomfortable. She had a lot of social anxiety, and she couldn't really, even thought maybe she'd go back to the village. She's never heard of social anxiety disorder. She's never sought treatment. What should we be doing for her, if anything? All right, and then this becomes increasingly controversial. Case C, Cliff. He works in a marketing company in Nairobi. He gives presentations, and he feels that he's a little bit stuttery. He's not as fluent as his colleagues, gets anxious, and he will only really rise up in the company if he gets a lot quicker in social settings and is a lot smoother. And he's been reading on the internet about this drug called paroxetine for social anxiety disorder. And so he comes into your private practice in Nairobi, says, I want paroxetine so that I can do better at work. Any particular thoughts off the cuff of your top of your head? Please, Professor Patel. Say again?
Case number 2, I can associate with.
Oh, you can do case number 2. But now, how about case number 3? What would you do? You're the clinician. Would you give this man an antidepressant? Would you give him paroxetine? You would not. I see lots of no's. Any yeses?
Of course.
Of course. So we have a problem here.
It's not antidepressant, it's SRI.
I beg your pardon?
It's not antidepressant, it's SRI.
Professor Zara has developed the NBN, which you got to talk later. Okay, he'll explain to you why he is attacking me. It's okay. Not an antidepressant. I use this word several times in this talk, so apologies in advance. You say yes. Any particular reason why, so that we understand?
I think that, he's suffering. You give him medication that is safe, and then you can see what is the effect. If you benefit, then it makes sense to continue. If it does not, then don't. But according to the description there, it's somewhat in the neighborhood between social anxiety and OCD, kind of monitoring himself. And for both conditions, SRI are good medication.
All right. Does anyone want to counter Professor Zahar? Please, I need a direct criticism. Please. Oh, you're going to agree? No, I want a disagreement. Any disagreement, please.
So, I think it should first start by assessing the severity of the symptoms in terms of how it's impairing its functioning. So, before I start him on.
Well, he's doing well. He's a manager, I think as we said. He works in a marketing company, but he's not getting to the next level. But I mean, he brings a take-home package that is way ahead of your average person in Nairobi already.
So the question is, you say he gets anxious. So that's where the chip fall. What does that mean? He gets anxious. How anxious? How does he perceive this to be impairing him? And so on and so forth. So I would really be interested in what does he gets anxious mean?
Okay, I mean, that's fair enough. We need to unpack it more. And that's probably spoken like a true clinician, because a clinician, yeah, I'm trying to be theoretical.
Yeah.
You know, what should we do? What should we do? Your clinician is going to say how anxious and go into the details. So that's actually helpful as
A
we think it
conversation I
through.
would have with somebody who says I get anxious, I say, how anxious? So when I'm in a room with many strange people, I'm a bit anxious when I enter the room. Then over time, I get comfortable with people and I'm fine. Like, yeah, that's like most humans. That's what I would say. So maybe you don't want to be like most humans, but yeah, most humans experience. So that's a conversation that a clinician would have, I think.
My understanding is that people presenting yesterday were a little bit anxious. That's my understanding. I'm seeing lots of yeses. Okay. So anyone that was totally not anxious, Professor Solomon.
Thank you very much. I think this is a dilemma I had when I was practicing psychiatry as a consultant psychiatrist in Canada.
First world
Because
problems.
we're used to treating severe cases in Africa, so I was constantly challenged by requests for medication by apparently healthy people. So
Interesting.
I spent the first 3 months trying to convince them not to take. Later on, I budged and I was giving them whatever they requested.
Why did you change?
Western psychiatry versus African psychiatry.
So yeah, context matters. In Cape Town, it's a little bit of a split because in the morning you might be working at Valkenburg Hospital, which is the same as Bootebeka, but in the afternoon you might be in Constantia, which is more like Canada. So we're a little bit divided. Okay. So if we go back to the talk, cognitive affective targets for enhancement. There are a range of them. Anxiety, it might be social anxiety, anxious temperament. You might want your mood to be better. You might want your emotions to be regulated. You might want better attention, better memory, particularly if you're a student. And interesting, there's a new field called moral enhancement. So some of you may feel that some of your colleagues need better pro-social behavior and better moral decision making, and that they should go on medication for that. And that's a serious argument in the moral philosophy literature. Now, people have been using enhancement drugs forever from plants, plant-derived drugs. So we have kava, for example, which is GABAergic. We have St. John's wort, which is probably serotonergic. In South Africa, we have a herb called Scaletium, which is probably also serotonergic. Here in East Africa, we have cat and other drugs that are dopaminergic and that help us with cognition. And the new push for psychedelics, part of that, the interest in psychedelics is that psilocybin and related drugs will help us be more one with nature, be better with one another. Oxytocin is another drug that's been called the love drug, will help us get on better with people. So recently there have been a bunch of papers on cognitive affective enhancement looking at a bunch of different mechanisms of action. So I won't take you through all of these, and I probably left out several. Oops. But there are multiple drugs. In one of these review articles, there were over 50 different kinds of drugs that have been used recently or suggested recently for cognitive or affective enhancement. And they range from things that pharma is producing, Me Too drugs that we talked about, to herbs that have been used for thousands of years, like ginseng. Now, the term cosmetic psychopharmacology, which is similar to cosmetic surgery, was put out by this man, Peter Kramer, I think in 1983, in this book called Listening to Prozac. So Prozac had just come out. I remember this my slides somehow always jump ahead, so apologies for that. I was a resident in psychiatry in the United States, and I was very excited to be giving my first prescriptions of fluoxetine, and they'd just come out on the market. And Peter Kramer, a psychiatrist, in Providence, Rhode Island, wrote this book which said that, in his opinion, people that had been in psychotherapy for years with him, and they were given fluoxetine, they no longer needed the psychotherapy. They became changed people. And they didn't have a major depression. They just were able to deal with social situations better. Their mood was improved sufficiently, and he called this cosmetic psychopharmacology. This book has had enormous influence and probably contributed to Prozac becoming the first blockbuster, one of the first blockbuster drugs in psychiatry. Blockbuster being defined as $1 billion profit. Now, there are a whole range of different kinds of enhancement techniques other than medication. So some of us go to fancy universities, some of us do a lot of exercise. Increasingly, there's this thing of body hacking or biohacking. In biohacking, you buy transcranial current, a little machine at home, and you put it in. There are a whole range of companies now on the internet that sell devices that you can use to make yourself cognitively and effectively enhanced. So we live in a world where this is kind of happening all the time, and drugs is just one kind of way to enhance yourself. And this has led to a lot of work in philosophy and a whole new field. The field is called neuroethics. Judy Illes is one of the founders of this field. She's a Canadian neuroscientist who now works full-time in this. Barbara Sahakian is a well-known British person. This book is fascinating. This book is called On Speed, and it's by Nicholas Rasmussen, and describes amphetamine use in North America and elsewhere in the world, but particularly in North America. And it's a good read. It's an interesting read which taught me a whole lot of things. One of the things is that it turns out that cocaine has been marketed since the 1860s. Cocaine was marketed by Merck. Merck is a big German. The Germans were ahead in psychopharmacology and pharmacology in general in the 1800s. They developed all the drugs, isolating them from plants. So you get your coca plant, the German scientists isolated cocaine, and immediately marketed it for fatigue and depression. Who was one of their first spokesperson? Sigmund Freud. One of his publications was called On Cocaine. He wrote that as just having graduated from medical school. And he used cases, I'm just going to have to keep going back. He used cases that he described from a Park Davis brochure. Park Davis is an American company that is also starting to market cocaine. Cocaine was initially in Coca-Cola. It was widely used. Freud, being a medical student, didn't realize that these were anecdotes made up by marketing executives. So in his first book on cocaine, it's completely unscientific. These were not real cases. It takes a few years of training before you realize what is drug company and what's real. And it turns out that Freud got confused about this. In the 1930s, the Americans started marketing amphetamine or benzodrine, and they marketed it as antidepressant. I've been told many times that psychopharmacology began in the 50s. It didn't begin in the 50s. It was much earlier than that, and was very sophisticated. Harvard-based psychiatrist put up pictures of the brain, put up pictures of the dopaminergic system, put up pictures of amphetamine, and said, here's translational neuroscience, and this is why you need to be on amphetamines. So this idea of translational neuroscience, which you heard from Bill yesterday as the way forward for psychiatry, it's been going on for over a century. And has to be a little careful here, because literally millions of tablets of amphetamine were marketed in the States. And then during the 60s became part of the beatnik kind of approach to living. Everyone was on amphetamines. And by the end of the 60s, the FDA said, whoa. And there was strict law, no more amphetamines unless you get it in triplicate, whatever. And the reason was there was an epidemic of addiction, right? That millions of Americans were addicted to benzodrine. What was your experience during the 60s? You were too young. You weren't taking them. Okay, fine. Other interesting thing, World War II, the Germans used Pervitin. Remember I said the Germans were ahead of the game? So they had developed this drug called methamphetamine, which is now causes 1 in 4 admissions in Cape Town. 1 in 4 admissions is for methamphetamine psychosis. The German troops felt that this contributed their ability in the Blitzkrieg to just overtake France. Their tanks went through the night, and they just, much quicker than anticipated, moved into Europe. The Allies saw this and said, right, this is a good thing. And they didn't have methamphetamine, but they had Benzedrine. And the UK military used 72 million tablets of Benzedrine in the Second World War. And it turns out, if you want to do good science, don't rely on the universities. The best science is always done by the military because the stakes are high, and they've got money. And so the military always does very, very good science. And they did several absolutely state-of-the-art placebo-controlled trials of Benzedrine. And the initial findings were that it improved performance, but over time, the military also saw the negative effects, including psychosis. So this is what the UK Air Force wrote at the time. Benzedrine has the effect of causing the individual to feel on top of things and able to carry on with his duties without rest. He feels he is doing well, when in fact he's making all sorts of mistakes. Straight from randomized controlled trial done by the United Kingdom Air Force. And so the author of this book, I'm not 100% sure he's absolutely right, but his argument is the drug raised morale and it raised mood. And so it made men fight harder and the men liked it. It was simply too useful for the military to do without it, regardless of what the science had to say. And so I find that fascinating. The Germans, the Japanese, the British, the Americans were all taking this stuff because it improved their mood, improved their energy. It's unclear, though, whether it actually improved their performance. Okay, so let me move on to some empirical data then. So here's a randomized systematic review of 19 randomized controlled trials on methylphenidate. They looked at 6 cognitive domains. In this particular meta-analysis, they didn't present effect sizes. They said it improved memory. Methylphenidate, Ritalin, improves memory, but not attention, mood, or executive functions. The authors emphasize that there's potentially a U-shaped function, that is, at low doses, you do better, but as soon as you get up to high doses, you start getting impaired. This is the Yerkes-Dodson law. This is well known, and these particular authors argued that that's why you're getting these sorts of findings. And they also said the lack of positive objective effects of methylphenidate should be propagated to discourage use for enhancement purposes. I mentioned Constantia in Cape Town. Maybe a third of kids are on methylphenidate. I mean, that's maybe a slight exaggeration. A third of parents ask for their kids to be on methylphenidate. That would not be an exaggeration. And the authors argue, don't do that. And Farah is a neuroethicist. She did some empirical work in this, and she says the motivational effects is least as pronounced as the cognitive effects. And so this goes back to the British Air Force findings, that it's not just about cognition, but it makes you more motivated, so you feel like you're doing better. A little bit later, a more recent one where they do provide effect sizes, looked at various cognitive domains like attention, working memory, and recall, and the authors argued that overall, there was a small overall effect on cognition. So that's interesting, but not on certain things, like not on selective attention, not on working memory. So it varies. Amphetamine, a little more thought to be a bit more potent than methylphenidate. It would be your second line drug for attention deficit disorder. You'd first begin with methylphenidate. If that doesn't work, you might go on to amphetamine. More difficult to get in South Africa. It's hard to get because of all the regulations around it. And in this meta-analysis from the same authors, Roberts and colleagues, no effect on enhancement. a little bit counterintuitive. I would have thought there'd be some effect at least. But again, maybe these studies were better at dissecting out what's actually cognitive from how you feel about your cognition. Now, more recently being used by university students, I don't know about Nairobi, but certainly in Cape Town, massive amounts of modafinil are being consumed by students. In fact, in a recent survey of German surgeons, 1 in 5 German surgeons uses modafinil to improve their surgical techniques. So here we have 31 trials. It's a 2010 article, maintained wakefulness, memory and executive functions in sleep-deprived individuals. So the surgeons don't get any sleep. You're training in surgery. You work through the night. Probably the modafinil helps, according to this. But note the last sentence, repeated doses are unable to prevent deterioration of cognitive performance over a longer period and possibly induce overconfidence. So rather than work through the night and take modafinil, change the laws that surgeons don't work 24 hours continuously. So that's happened in the States. People are not allowed to work for 24 hours, and I think that's probably a good thing. All right, more recent one, 24 studies, variable improvements, and then what I want to draw your attention, some negative consequences, impairments in divergent creative thinking. So these drugs have got pluses and minuses, potentially. And then the most recent one, no significant effect for attention, memory, recall, and a very small overall effect size, tiny effect size overall for modafinil. Similar finding from another meta-analysis published at the same time, very small overall effect with nothing on attention. All right, moving along, there are these other kinds of medications that I mentioned, like acetylcholinesterase inhibitors, memantine, the glutamatergic drug is now used. The authors here say inconsistent effects, insufficient evidence. There are a bunch of drugs that other drugs that act on glutamatergic systems. In this analysis of drugs that act at the NMDA glycine site, some pro-cognitive effects. The authors here are pushing for the use, but they admit that the evidence is limited with few studies, small sample sizes. People might be taking omega-3 polyunsaturated fatty acids, definitely very big in Cape Town. There are a couple of narrative reviews, and you see strikingly different kinds of trials. In 2 trials, a small benefit in attention in healthy elderly participants with ApoE4, some improvement in verbal memory in healthy postmenopausal women, and a study done in the US military officers, so it's where it really counts, no benefit. And then another study again, no benefit in cognition in midlife participants. Ginseng and ginkgo biloba, used for thousands of years. When you do a Cochrane review, 2010, lack of evidence to show a cognitive enhancing effect in healthy participants, no ascertainable positive effects on cognitive functions in healthy individuals. Caffeine. Meta-analysis of people, healthy people who are sleep deprived. In healthy people that are sleep deprived, it improves a lot of things, response time, accuracy, reaction time, so on. And the authors conclude that it's an effective agent to counter cognitive and physical impairments associated with sleep loss. How about exercise? People use caffeine to help them during sports. This meta-analysis said it's only a few studies, but it improved attention, accuracy, and speed, and may do other things as well, including mood, though. But more recent work, just speaking to the complexity of the issue, one meta-analysis says they agree. It does do all of these things. It does improve attention on simple and complex tasks. This is not due to withdrawal reversal. But this group of authors has published a number of papers, James and colleagues, saying, yes, of course it improves performance. And that is entirely due to reversal of adverse withdrawal effects. I don't know if you're like me, I have coffee every single day. and then some days I'm not able to have coffee for religious or other reasons, it's a nightmare. It's an absolute nightmare. I go into severe withdrawal. And of course I would do better on my tasks if I had a cup of coffee that day. And that's their argument. Their argument is caffeine does nothing for you, but that it's very helpful when you go into withdrawal, as many of us do every day. So I haven't been into the individual studies close enough that I can draw. I hope to read this when I have time, but I myself don't know who's correct here. This is a sobering meta-analysis that just came out. Those of us of a certain vintage are increasingly concerned about our subjective cognitive decline, our inability to remember words, our difficulty word finding. I've thought of lion's mane mushroom. It's not in here, but lion's mane mushroom is widely touted in Cape Town as good for people like me. According to this particular meta-analysis, nada, zilch, zero, ain't gonna work. Nothing works. This is very sad. All right. So those are the meta-analyses, but it may be useful just to look at one or two trials in a bit more detail. So I'm just going to do that. This is a paper which I like the title. It's called Feeling Smart, Effects of Caffeine and Glucose on Cognition, Mood, and Self-Judgment. So glucose is another thing that people will take during sports or might take. When I was writing exams, I always took in sweets on the assumption that a little bit of glucose would help me during the exam. According to this paper, that's not true. It doesn't help you at all. But it does make you feel confident, more confident. And so you kind of feel that you have preserved mental energy. And in that sense, I encourage all of you that use glucose during exams to continue with that. This is a lovely paper where they gave to chess players methylphenidate, modafinil, caffeine, and placebo. So 39 male participants, talk about that another time, double-blind, placebo-controlled trial, no significant effects on chess performance of the drugs. The drugs, interestingly, increased average reflection time per game, but this is speed chess. So if you were on a drug, you did worse. You lost more games because you were thinking harder. So they argue that the effects of these drugs differ depending on whether there are time constraints. There's worse performance on these drugs if you're under time constraints. And many of us are under time constraints. So many students that are busy taking these drugs aren't aware of this particular finding, that in fact they may be harming themselves or putting themselves at a disadvantage. Sorry, did it go off? Yeah, please. Yeah.
Just wondering that some of these drugs, you get spaced out.
Yeah.
Is that why they get the time that they're not aware of?
No. You do get that with other drugs. For example, psilocybin or serotonergic drugs, perhaps, but not with these. I don't think people on methylphenidate feel spaced out. I think they feel more focused in general. It's like with caffeine; you feel slightly more focused. I'd say that what's key, and Professor Newton's talk was very helpful here. There's such a lot going on here. The genetics, what about your underlying genetics? You may or may not metabolize caffeine quick or slow. So that's going to vary, and you can't determine that in 39 people. It depends a lot on what you believe about caffeine. It's one thing if you think it's going to help you, this creates expectancy effects. Remember, placebo response rates are very high in anxiety, depression, ADHD, and that's because of expectancy effects. We talked about how in certain cultures, it's only going to work if it's intramuscular. That's entirely an expectancy effect. It has no basis in reality. And it also ignores, this issue of the wonderful taste and aroma of a good cup of coffee. That is just completely ignored here, because that can be very important if you're playing chess, to have something that you enjoy. Okay, this is one argument that people put forward, which is that it's all dose related. At low dose, you get cognitive enhancement, slightly higher, you start to get addiction, slightly higher, you get psychosis and eventual death. I think this is nice, and from a biological perspective, makes a lot of sense. And I know some people in the audience know a lot more about dopamine than me. But I just want to, in asking your opinion, there's a lot else going on here. So it's yes, there's dose, but as we discussed, there's your underlying genetics. As we discussed, there's the side effects, there's temporal factors, there's how you're getting it. Are you getting it intravenously, orally? I mean, all of these things are going to change and rock the equation. It's not just dose. So doses, I would
I
think.
think people have everybody develops their own personal relationship with dopamine. And, there's a lot of electrophysiological studies, for example, that you titrate individuals, and then you do the experiment and try to determine if something has an effect, because you determine where the individual is on the curve, whether it's TMS and, when do you finally activate the motor cortex. There's a lot of variance in that, and the variance is kind of the equivalent of pharmacokinetic variance and the relationship that each individual has with dopamine. And none of these studies remotely take that into consideration. That doesn't mean they're doing something wrong, it's just the state of the art. And you can't afford, your grant can't afford you to run everybody through a whole series of...
Great.
But I think that's, and then again, maybe the subjective effect is the most important effect of all, as you were alluding to. The smell of coffee is all at the condition cue. It's like, my day is starting, I'm ready. Yeah, that may be the whole...
So I just want to I find Peter's answer very helpful, and I think it ties in with what Lukoya is saying. So Peter's basic neuroscience actually understands dopamine neurophysiology in a way that clinicians don't. But Lukoya said, just ask about the anxiety. I think it's because it's going to be dependent on that individual, and that's what psychiatrists do, is they basically do what you're suggesting. They give a low dose, see how it works. Person doesn't like it, they try a different drug. If they might escalate. I mean, this is also again what Charles was saying. It's every patient is a experiment, and you kind of experiment in a one-to-one way, and that's probably the theme here. That's probably going to be the take-home message. So we've got to do it a little bit earlier, but yeah, the science is important. And at the end of the day, you work with the individual person in front of you.
It's relatively, with caffeine in particular, it's relatively harmless. So if the person wants to believe that they're doing better.
And with caffeine, I meant to show you one thing. Oh, here it is. Association between caffeine consumption, cognitive decline, and dementia. There's growing evidence that caffeine consumption is associated with later onset dementia. So for those of us that like coffee, that's sort of interesting. This is really well replicated in the literature now. Exactly the causality is open. Perhaps people that like their morning cup of coffee are the sort of people that do things like exercise and other things to prevent dementia. So the causality is unclear. But for those of us that like coffee, that's useful. Okay, so... let me now go to sort of the hardest part of this talk, which is just the conceptual framework here. So because I can't remember anything anymore with my advanced age, I've now become a philosopher, and that's what I do with my time. So I'm just going to introduce you to some philosophy, and the philosophers will end up basically saying that's an individual decision to give away the final word. Okay, so you have what I want to discuss with you as being the classical view in philosophy. And this goes back to people like Plato on the left, and to a man you may have heard of, Robert Spitzer. Spitzer changed the world of psychiatry. He's probably the most important psychiatrist in the 20th century because he developed the DSM-3 and was instrumental in subsequent editions as well. And he basically said, like Plato, diseases have got necessary and sufficient criteria. Here are the criteria Plato set for being a square. Equal sides, 90-degree angles, it's a square. It's there forever. Spitzer, depression is 5 out of 9 symptoms. That's depression. So as I said, necessary and sufficient characteristics. You know, you've got your periodic table in chemistry. Beautiful rows, beautiful columns. You know, your molecule fits into row 2, column 3, because it's got so many neutrons or whatever it is, I can't remember, going back to high school physics. And, you know, Spitzer tries to do the same thing for psychiatry. Yeah, when DSM-3 came out, it was beautiful because it put everything so elegantly. You didn't have to remember all these German psychiatrists who like wrote thousands of words about illness. So we talked yesterday, I think you asked the question, is it a disease or is it a symptom? For Spitzer and the German psychiatrists, Kraepelin in particular, it's a disease. It's a disease entity, and so it fits in row 2, column 3, and you give drug X accordingly. That is the theory. Now you've got a bunch of other people. I've picked 2 of them because they're particularly well known. The guy on the left is a guy by the name of Wittgenstein, one of the most important philosophers of the last century, and the guy on the right is a guy called Foucault, a very well-known French philosopher. These people are impossible to read. I mean, you try to read them, they make no sense whatsoever. Nevertheless, they've had a major influence, and one of their influences has been on anti-psychiatry, because they argue, psychiatry, we're not dealing with squares, we're not dealing with the periodic table. You've completely messed up, you're using the wrong way of thinking. So they would argue, rather think, for example, about something that's edible. I went to a wedding, actually a relative's wedding in Cameroon. They were very proud to serve monkey at the wedding. Now that doesn't go down well in Cape Town. Monkeys are not edible in Cape Town. So what's edible changes from time to time and place to place. And your definition of edible is not my definition of edible. It's a culture-bound thing, it's a context-bound thing. And similarly, when you're talking about psychiatric disorders, these reflect our particular era and our particular power relationships. So this kind of perspective, which I'm going to call critical, plays a major role in current debates about psychiatry. It's incredibly influential. It influences things like neurodiversity studies. It influences the new field, which is called MAD studies. And here, clinicians, psychiatrists are really part of the hegemony, part of the discourse that controls other people. We have the power, and you know, sometime tomorrow someone else will have the power. All right, and so what I want to argue for is an integrative view which says, look, both of these points of view, the classical and the critical, have some important contributions to make, but they both also have some flaws. And so what you have to really think about is combining the best aspects of both. And Aristotle happens to be one of my favorite people, but he wasn't the only person working at the time. He was working with a bunch of other people. And Karl Jaspers, a German psychiatrist, working during Second World War, thereabouts, before and after, with his general psychopathology, actually I'm not sure, came out before the Second World War, is someone who really straddles the divide between the classical and the critical and puts together a nice integrative story. So these are 2 heroes of mine, and what they would argue is along this line. Of course, science is a social activity. You can't get away from that. We're humans, so everything we as humans do, including science, is theory-bound, it's value-laden. Science has particular values, and it doesn't just come from up above. It is human-made. But still, the main thing about science, the amazing thing about science, is that we do discover real structures, real processes, and real mechanisms. So when Peter says this is the way dopamine works, okay, that's interesting. We didn't know that before. So similarly, DSM, although it's theory-bound and value-laden, and we can talk about the theories, we can talk about the values that are in DSM, it is based on a knowledge of disease mechanisms, and it does direct our treatment. It doesn't direct our treatment like the periodic table does, column X, drug Y. It's a fuzzy direction. Remember what Bill said yesterday. Bill said DSM is purely consensus bound, and so it doesn't tell us anything of value in treatment. Now, there's something correct about that it is consensus bound and that it doesn't absolutely direct your treatment, but it ignores the fact that there is a certain amount of science to DSM. And so I think a comment that he made, and I did say this to him at lunch, he's falling into the trap of Wittgenstein and Foucault, and he's a little bit anti-psychiatry. Now, I'm not saying that DSM tells you what drug to use, because unfortunately we use antidepressants for, and this is the point of the NBN, which we'll hear tomorrow, we use antidepressants for depression, for anxiety, for sleep, for PTSD. And so, this one kind of drug works for across DSM categories. So clearly DSM is not the periodic table. It's not the periodic table. It's very fuzzy. But that stands to absolute reason, right? Because we're dealing with mental disorders. So it's not dealing with molecules. It's much more complex, much more fuzzy. And that's the beauty of psychiatry. That's where psychiatry differs from dermatology, for example. Not to mention anyone. Okay. So in other words, what I want to put as a concept to you is conceptual wisdom. The wisdom is not to fall in the trap of Plato, but also not to fall in the trap of the critics who are completely dismissive of all of psychiatry, and to have a somewhat balanced point of view, a somewhat integrative point of view. Okay, so let's see how that works. Okay, so what about the distinction then between treatment and enhancement? So for some people, treatment is about addressing your underlying dysfunction. In the British system, NHS pays for your treatment. Enhancement is something that if you're a Canadian, you can afford. You pay for it out of pocket because it's going to enhance you. But I just want to argue, potentially, I'm still thinking this through, but the Cliff, case C, where we had a disagreement, it's hard to draw that line. Professor Zohar said, you're going to treat him. He's clearly at risk of, I see him as someone who's basically ill. That's what he said. He said, it's safe, the drug is safe, let's do it. This is not only in psychiatry, it's also in physical illnesses. So when we give someone fluoride in the toothpaste, what is going on with fluoride? Is fluoride an enhancement, or is fluoride a medical intervention to prevent caries? So Joseph would argue that fluoride is a medical intervention, we should all get it. And I sort of agree with it. I'm tempted to agree with that. It's difficult to say whether fluoride is an enhancement or a treatment. Basically, it's a good thing, and we should give it to our kids because they'll get less dental stuff. It doesn't really matter whether we call it a treatment or an enhancement. These lines can be fuzzy. Life is not like that. Life is not all squares and triangles. When it comes to medicine, things are fuzzy, and we can agree to give fluoride. The fuzziness is also seen in subthreshold disorders, which I think, again, we've sort of alluded to. So this is an example from Ron Kessler, who's a famous psychiatric epidemiologist, who talks about hypercholesterolemia. Early on, to be diagnosed with hypercholesterolemia, you had to have cholesterol levels up here. They introduced the statins, and the American cardiologist said, no, it's here. Then they introduced generic statins, and the cardiologist said, no, it's down here. And the reason is they were being paid by the pharmaceutical companies to say this. No, because they had figured out that, the cost-benefit ratio of statins is, you should all be on statins. Basically, everyone should be on statins. Now, I'm being obviously tongue-in-cheek about statins, but there's something very similar going on with statins and antidepressants. If you've got familial hypercholesterolemia and your cholesterol is 10 times as much as everyone and you're 18, you're going to die by the time you're 30 from a heart attack. In South Africa, we've got these groups of people that have that. And a statin at that age is absolutely life-saving. The effect size is Cohen's D of 10. I'm making this up. It's massive. If you are 70, 75, and your cholesterol is a little bit elevated, and you go on a statin, you'll live maybe 3 weeks longer than the next person. So if you do a trial in 1 million people, it'll be significant, and your cardiologist will tell you to do it. But the effect size is 0.002. So this is interesting to me. I mean, in some cases, an antidepressant has got an effect size of 10. You have to take it. Patient with bipolar, strong family history, bipolar disorder, suicidal, give them the antidepressant, you get them out of there, you've saved a life, no question. Someone like me, who's sort of dysthymic, sort of, on the elderly side, the antidepressant might be helpful, but, not going to make much difference for me. I'm going to be like in a cruddy mood and be obnoxious, difficult, whether or not you give me this antidepressant. Okay, all right, so you might be like Bill yesterday. I'm sorry to keep talking about Bill, but Bill referred to Tom Insel, and Tom Insel says, when we've got clinical neuroscience, we'll be able to delineate the brain circuitry into diseases that are treated by psychiatrists. This is complete nonsense, because RDoC constructs by themselves are dimensional. They don't cut reality. And mental disorders, turns out they're not like squares. They're just not like squares. They have overlapping genetics. They have overlapping brain signatures. And we don't have biomarkers in medicine, in psychiatry. In psychiatry we do not have biomarkers. I'm going to challenge you, and I'm going to say we're never going to have biomarkers for anxiety. And the reason we're never going to have biomarkers for anxiety is what Lukoya said. Anxiety is normal. How can you have a biomarker for a normal emotion? Okay, I'm happy to take argument about that. All right, but this is Enigma, which is, we might have talked about as the world's largest brain imaging consortium. It just shows there's no brain. They get Paul Thompson is great. He's wonderful, and Zul, we should talk with him. And he gets millions of dollars of research funds, but he hasn't found a brain signature, not yet. The geneticists, Patrick O'Sullivan, brilliant, millions of dollars for genetics research. The genes all overlap, like there's no genetic signature for anything. All right, another one of my favorite people is a man by the name of Randy Ness. He is the father of evolutionary medicine, as well as the father of evolutionary psychiatry. I strongly encourage you to read his book, Why We Get Sick. He emphasizes that a lot of what you see in psychiatry is normal. A lot of it is anxiety, which is adaptive. And one of the best things you as a clinician can do is to normalize what is going on for the patient. But there's a man by the name of Jerome Wakefield who's been extremely influential in philosophy of psychiatry, and he argues that every mental disorder is a dysfunction. And so you get a departure from what's evolutionarily designed, and that is what a mental disorder is, and that is what you treat. I think he's wrong. Much as I respect him enormously, the problem is if you've got something like a fever, a cough, anxiety, we as clinicians are going to treat those things, even though they're normal. Like fever is normal. If you don't have fever, you're going to be sick longer. If you don't have a cough, you're going to be sick longer. But if you come into my office, I'm going to give you paracetamol for your pyrexia. That's what I do as a good doctor. You'll be less distressed. You might avoid febrile seizures if you're an infant. It's good medicine to cut off that evolutionary design defense. So basically, evolution doesn't tell us when to treat and when not to treat. Sad. Okay, so biology doesn't help us, evolution doesn't help us, but it doesn't mean, and this is what Paul was working towards, that anything goes. It's not true that anything goes. For example, I introduce you to the philosophical distinction between doctoring and schmoctoring. Turns out there's a philosophical literature on doctoring versus schmoctoring. You may not be familiar with it, but here it is in one slide. So doctoring is treatments that aim to distress, dysfunction, disability, plastic surgery after burn. Then we can talk about, well, what about people with macromastia? A woman who's in trouble from her macromastia because she has back pain, okay, and she's unable to move around easily and is starting to live in distress. Does the NHS pay for breast reduction or doesn't it? So the NHS, it turns out, will pay for breast reduction in a person who's got back pain because of macromastia. But you can see that it's on a sliding scale, and it's culturally bound and context bound, because some people might find, have different views of how that all works. Schmocktering is when you go to Brazil. In Brazil, there will be lots of plastic surgeons that will do the surgery to make you look more like your favorite celebrity. I cannot believe that there's any good reason for that. That seems to me, if you want to spend your money like that, that's fine. You want to be a surgeon that does that, that's fine. But please don't tell me that you are interested in relieving disease burden of mankind. You're doing something that's quite different from doctoring.
Relieving distress.
Well, no, you could argue, there is a counter-argument that if I don't look like Madonna, I feel enormous distress. I personally have trouble empathizing with that position. But then again, I'm not a woman, so I may be, missing something there. Okay, so we talked about conceptual wisdom. Let me talk about practical wisdom. Practical wisdom is an Aristotelian concept. It's about balance, it's about integration. And so let me say to you, let's try to be integrative. Should we use medication for Adam? Absolutely. Remember, he was this guy with a lot of depression, a lot of social anxiety, didn't respond to psychotherapy. Of course we're going to give him medication. There are good reasons for treating people with psychiatric disorders, mental disorders with medication. Ignore what Foucault says, ignore what Wittgenstein says, ignore what the anti-psychiatry Thomas Szasz says. They're wrong. They're absolutely wrong. There's a very good reason to treat Adam with an antidepressant. As Professor Zohar said, it's safe, it's effective, we've got a good evidence base. It's just the right thing to do. And we shouldn't be shy about saying it's the right thing to do. We should be proud about that. It's an easy one. Okay, so psychiatric treatment of typical mental disorders is defensible. It's based on a range of considerations like efficacy, safety, cost effectiveness. Now, what about Beth? Beth is the person that had social anxiety disorder. Now, people like me and Joseph are interested in anxiety disorders, so we think social anxiety disorder is real and we should treat it. But there are a lot of colleagues, some of my psychology colleagues, who would argue it's over-medication to use an SSRI for social anxiety disorder. This responds to CBT, and you shouldn't be using an SSRI for social anxiety disorder. And there's a sort of a philosophy to this, according to the classical people, you can divorce facts and values. According to Wittgenstein, facts and values can't be divorced. And what I want to sort of say from an integrated point of view, we can look at the facts and values here, and we can weigh them up. And so, in a particular case where the person says, I don't want to do CBT, I can't manage the CBT, I can defend giving paroxetine for social anxiety disorder. I can understand the psychologist's point of view that maybe we should consider CBT as potentially first line. We have to weigh it up. If the person says to you, this is chemical, my expectancy, I know my father had social anxiety, my grandfather had social anxiety, they both responded to paroxetine, and I now need paroxetine. It's the wrong thing to convince the person to do CBT. The person's telling you they want the medication. Give it a shot. If it works, great. If it doesn't work, try something else. So you think it through as a clinician, weighing it up. It's common sense in a way, but I'm just giving you the thinking. Now, what about Cliff? He's the guy who wants to do better as a marketing director. He's the psychiatry young person coming to FCNP and wanting to outperform their colleagues. And what do? There's what some people would say, and this is there's a document called President's Commission on Neuropsychopharmacology. So this was brought in by the Republicans' conservative ethics group, and they said, absolutely not. No. You're a young up-and-coming scientist. You want to take drugs to do better at work? Absolutely not. And that position has been called by some in philosophy pharmacological Calvinism. At one point, one theologist sort of argued against benzodiazepines on the grounds that it's better to suffer than to take a benzodiazepine. So hence the term pharmacological Calvinism. Don't take a benzodiazepine. We're put here on earth with a certain amount of suffering, and that's good for you. The opposition point of view can go either way. The critical people sometimes argue pharma is evil. We heard about that today. Pharma is evil. Anything pharma tells you to do, benzodiazepines, it's going to be bad for you. Don't take it. Right? So there's that strong voice in the critical position. All drugs are bad for you. All pharma is bad for you. But there's another subgroup within the critical position, within the MAD studies and whatever, which says, sure, try everything. Psilocybin will help you grow. And so within anti-psychiatry, people that are very anti-SSRIs, anti-benzodiazepines, anti-anything that Professor Zohar will prescribe, totally happy to try psilocybin, totally happy to try ibogaine, totally happy to try any psychedelic, because, hey, it's not pharma, and I'm going to grow. And so that position we would call pharmacological utopianism. So Aldous Huxley wrote about this. We're going to try different medications which will bring us to nirvana in our time. And I'm arguing both of these positions are wrong. Okay, it's somewhere in between. You need more data. You need much more data. When you've got the data, then you can reasonably debate your way forward. So we can have a reasonable debate about Cliff. One of the things that Joseph said is, well, the data are there. It's safe. I'm not much sure about that. We have no data on people who are healthy on SSRIs. We have vanishingly little data. So I agree, you can make an argument, but we have all this data on people with SSRIs and depression, so it's going to be fine. But actually, we don't have big studies of healthy people on SSRIs. So the data is a little tricky. So basically, to finish up, I'm arguing for finding a balance between the value of accepting ourselves, accepting suffering. There's an argument that suffering is important. That's how you grow. I believe that. But I also believe, there's value to molding nature. You don't have to accept life exactly as it is. You can try to get past the suffering, and you should do so. So it's finding a balance between hope about future advances, hype about the current work. You've got to weigh up issues of efficacy and safety on the one hand, but I think why we're a little bit skeptical of the Canadian position, sorry Zul, but because they seem to be missing something. They're missing, the people that saw you are missing sort of this idea of working with authenticity, understanding that not everything, there's not a pill for every ill. They're somehow missing something perhaps. So we have to, weigh things up carefully, as good clinicians do, understanding the particular patient, particular context. So in summary, how's the energy? I don't know if I want to go through all of this. Basically, okay, well, let me do this very, very quickly. Okay, sure. Very, very quickly, I would argue, shouldn't medicalize problems of daily living, like exam stress. Exam stress is not a disease. But at the same time, again, to go to the other extreme, we now have social media addiction. We now have gaming addiction. We have to take those very, very seriously, like incredibly seriously. That is what's making our kids ill. And so we shouldn't ignore that. And then what I would also say is there's huge scope. The DSM is just your first step. After you've got your diagnosis, the next step is to do a detailed investigation per what Lukoya is saying. And there are ways of doing that for every disorder. So this is anxiety disorders. What we offer here is the way to standardize management. This idea is that of Mario Mai. He's editor of the World Psychiatry Journal. And he commissioned a series of articles which said, DSM is just the start. But after that, do this measure, this measure, this measure, standardize that so that we have a rational way of approaching depression, schizophrenia, and bipolar disorder. Strongly encourage you to read World Psychiatry. It's free. You can read it in the language of your choice, probably, I don't know about Kiswahili, but certainly Arabic. And it's a good read, and these articles in this series are particularly good. Okay, what about etiology? So the idea that what I want to just quickly argue for is there's never going to be a single cause of a mental disorder. It's not going to happen. A very occasional genetic deletion will cause some sort of psychotic thing, like once in a blue moon. Very occasionally we'll find a spirochete that causes schizophrenia. But for something like anxiety, it's going to be like 1,000 billion factors that are contributing to your anxiety disorder. And so this idea that we're just going to get the one thing, it's driving us mad. And it's the wrong approach. We must have a more complicated view. We must have a biopsychosocial approach. And we are always going to be a little bit fuzzy about whether or not we're treating or enhancing or whatever. We're just going to do the best we can. This is an article about that. And then finally about treatment. One of the most important things in the clinical interview, in my view, is the question to the patient, what's your theory? What do you think causes this? You know, I have a theory of OCD, but what's your theory? And we go from there. So if your theory is chemical, great. If your theory is childhood trauma, we'll talk more about it. If your theory, whatever, we negotiate this and we have shared decision-making around that. But I have to particularize my treatment because whatever the person says, I'm then going to shift slightly as to what I do. I'm going to individualize my thing.